So this is a series. This is a series called the Global Health Learning Network. And what is special about this in my experience is the interdisciplinary nature. We talk about multidisciplinarity, interdisciplinarity, transdisciplinarity. What exactly do we mean? We mean professions coming together for the good of population health. And this is truly an interdisciplinary enterprise. Gradually, we are approaching transdisciplinary approaches where every project of a university or of a department is around human wellness and human health. Why should it not be so? But this is a unique series, and we've been doing this for the second year now. It's a joint venture of the School of Epidemiology Public Health, the BRIA Research Institute, the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment and Health Equity, as well as the International and Global Health Office. I am pleased to be moderating today. My name is David Ponca. I am the lead of the Besser Center for Global Family Medicine, which tries to unite the Departments of Family Medicine in Canada and their overseas partners in terms of leveraging projects, resources, and efforts. Global health is indeed all about leverage. And today we are very honored to have a speaker who has shown much experience both in Canada and overseas, Dr. Alfredo E. Walker. Welcome, Dr. Walker. I will introduce you. You are a registered Category A forensic pathologist for the Ontario Forensic Pathology Service, based within our Eastern Ontario Regional Forensic Pathology Unit at the Ottawa Hospital General Campus. You've held this position for 11 years. You also hold an academic appointment as assistant professor in the Department of Pathology and Laboratory Medicine at the faculty, and you are vice chair and director of education. We hope you will incorporate some experiences from those roles as well. You are the inaugural program director for the PGY6 Fellowship in Forensic Pathology, and this started this year, July 1st, 2022. Dr. Walker is a medical graduate of the School of Medicine, Faculty of Medical Sciences, University of the West Indies, San Augustine Campus, Republic of Trinidad and Tobago, where I've had the pleasure of visiting a couple of my times on my way to Guyana. You completed both your residency in anatomical pathology and fellowship in forensic pathology in the United Kingdom. You function as a resource person for pathologists who perform medical legal postmortem examinations in the whole Caribbean region, including Belize, St. Lucia, St. Vincent and the Grenadines, and Trinidad and Tobago. Finally, let me just say that you are a member of the many advisory boards, including international organizations such as Physicians for Human Rights and the Medical Legal Death Investigation International Community of Practice, which is supported by the Data for Health initiative of the CDC Foundation. So it's a real honor to have you with us. And thank you very much for reflecting with us on infectious diseases in general, and as they relate to re-emerging global public health threats. Thank you, Dr. Walker.
Thank you very much, Dr. Ponca, for that introduction. Good afternoon, one and all. So if I can just share my screen. So I have been tasked with speaking to you all on infectious diseases, a re-emerging global threat. So let's get right into it. At the end of this presentation, participants will be able to, one, explain the reasons behind the reemergence of infectious diseases, two, discuss the infectious disease epidemics of the last century, and three, discuss the etiology, pathology, and postmortem considerations of COVID-19 disease. So let us look at global public health threats which have occurred in the 21st century. There are many opportunities for global public health threats to exist, and this is as a result of the highly mobile, interdependent, and interconnected world in which we now live. This affords for the rapid spread of infectious diseases once an outbreak develops. And against the background of that as well, we live in a time where radionuclear threats are a real and present danger, as well as their other toxic threats. Infectious diseases have been shown to be spreading much faster than any time previously in the history of the world. An outbreak in one part of the world is only but a few hours away in terms of a flight from another part. If we look at re-emergent infectious diseases, what are they? These are infectious diseases that have, one, either recently appeared within a population, or two, exhibited rapid increases in their incidence or prevalence in a geographic area. And the causes of this are multifactorial. However, broadly, they can be previously undetected or unknown infectious agents, which have now been identified, or known agents which have spread to new geographic regions or have entered new at-risk populations. And thirdly, re-emergence of infectious diseases, which is the crux of today's talk. So re-emergent infectious diseases have reappeared, are infectious diseases that have reappeared after exhibiting significant declines in prevalence over decades. And again, the causes for this are multifactorial, but breakdown in public health control measures, development of new strains of pathogens, so biological evolution is also a factor, but overwhelmingly, human behavior is the main contributor. Overuse of antibiotics leading to drug resistance for the bacterial infections, population overgrowth and migration going into new areas which were not previously inhabited. International air travel, again, this affords for the quick spread of diseases from one part of the globe to another. Poverty, so living in squalid conditions, not having appropriate nutrition, placing the at-risk population at an increased risk over others. Wars and all that goes with it in terms of, a drawdown on normal public health measures, basic healthcare, etc. And destructive ecological changes as a result of economic development and land use. What are the criteria for establishing a disease as an infectious disease? Well, first and foremost, you need an infectious agent, a biological agent. Secondly, you need an at-risk population, a vulnerable population in which that infectious agent can get into and spread. Thirdly, that infectious agent must be able to spread easily from person to person. And once it spreads, there must be some form of self-sustainability of the infection for it to perpetuate within the at-risk population. Zoonoses or zoonotic infections refers to transmission of an infectious agent that jumps animal species from animals to humans. And there's an increased risk of zoonotic infections once there's closer contact between mankind and animal species for all the reasons which have previously been described. This ability of an infectious agent to jump species from an animal reservoir to a human reservoir is what poses a very serious threat to human health. In 2007, the World Health Organization issued a report that said infectious diseases are emerging at unprecedented rates, with approximately 40 such diseases being identified since the 1970s. They tend to appear at a rate of 1 to 2 per year, and over the years, SARS, MERS, Ebola, chikungunya, avian flu, swine flu, Zika virus, and more recently, the bane of our existence for the last 2 years, the novel coronavirus, COVID-19. Collectively, these infectious diseases have accounted for in excess of 1,100 epidemics just in the last 5 years alone. So let us take a walk down history, the path of history, and look at some of the historical epidemics and pandemics which have occurred. So in the last century, in the 20th century, at the turn of the century, between 1918 and 1920, there was an influenza pandemic caused by an influenza A virus, H1N1 subtype, which was known as the Spanish flu. That exacted a toll of in excess of 50 million deaths. Between 1957 and 58, another influenza A virus caused a pandemic, this time H2N2, and that was the Asian flu, which accounted for, thankfully, a much lower death toll of only 1 to 4 million. 1968 to 1970, another influenza A virus, serotype H3N2, Hong Kong flu, 1 to 4 million again. From the early 80s till present day, the human immunodeficiency virus, the virus that causes AIDS, has caused the death of more than 32 million persons and is still a significant disease in some of the underdeveloped areas of the world today. In the latter part of the 1900s to the early 2000s, bovine spongiform encephalopathy, otherwise known as variant Creutzfeldt-Jakob disease, broke out in the United Kingdom and accounted for 178 deaths. In the 21st century, at the start of the 21st century, SARS came on the scene, was caused by SARS-CoV virus, coronavirus, and that was responsible for 774 deaths. Between 2003 and 2019, another influenza A virus, serotype H5N1, Asian flu, it affected Southeast Asia and Egypt, just under 500 deaths. 2009 to 2010, swine flu, another influenza A virus, worldwide epidemic between 150 and 600,000 deaths, thankfully. From 2012 till present day, MERS, worldwide infection, MERS coronavirus, just under 1,000. And between 2013 and 2016, West African Ebola virus emerged as an epidemic throughout the world, but originating in Guinea, Liberia, etc., and was responsible for just over 11,000 deaths. And then we have the COVID-19 virus, which has, I'm sure, since I first updated this slide, the number has gone up significantly. It's way in excess of that 5.5 million. So on January 20th this year, when I last downloaded from the WHO website, the number of deaths caused by COVID-19 was 5,589,000. Unfortunately, I didn't have the bandwidth to update it for today's presentation, but I'm sure it's at least another million. Other diseases, so smallpox, which is a variola virus, a member of the orthopox virus family. It has been in existence for at least 3,000 years with a 30% fatality rate. In the 20th century, it's estimated that smallpox caused between 300 million and 500 million deaths. So this is no small fry infectious disease. Smallpox it's transmitted via respiratory droplet infection. Early presentation, fever, back pain, nausea, vomiting, so pretty non-specific. Following the onset of those symptoms, 2 to 3 days later, vesicles appear that later become pustules, then crossed over and fall off. Lesions can also be seen in the nose and mouth, and there was no known treatment for it. And on the right of the slide, you can see some of the images which have been stolen from the internet that depict smallpox. Smallpox, however, afforded the opportunity for the development of the first vaccine against an infectious disease. And once it was developed, the World Health Organization launched a plan in 1967 to eradicate it. 13 years later, in 1980, the World Health Organization could have triumphantly announced that smallpox was the first infectious disease that was eradicated, and it was eradicated as a result of mass vaccination campaigns. Vaccine stockpile is maintained by the WHO in case of a re-emergence, but thankfully it's not something we have to think about on a large scale as occurred back then in the 60s. Plague is caused by Yersinia pestis, which is a gram-negative facultative anaerobic coccobacillus, with the reservoir of infection residing in the rodent population, and it's transmitted from the rodent reservoir population to humans via flea bites. Flea bites, direct contact with infected material, as well as inhalation of aerosolized infected material, are the three possible routes of infection with Yersinia pestis. And three clinical types of disease can develop: bubonic plague, septicemic plague, or pneumonic plague. Plague was otherwise known as the Black Death in the 14th century and caused the death of 50 million persons. And it holds the trophy in second place after smallpox as causing the highest number of deaths. There have been three pandemics in time. The first occurring in the 6th century, second in the late Middle Ages, and more recently in the mid-19th century, but to date, sporadic cases still develop throughout the world. The death rate is between 30 and 90% if untreated, but it drops significantly to only 10% if treated, and the treatment is simply antibiotics. Bubonic plague develops after bites with fleas. So of the three modalities of infection, flea bite results in bubonic plague, not septicemic or pneumonic plague, with the symptoms being fever, headache, malaise, or painful lymphadenopathy close to the site of entry of the organism, and that painful lymphadenopathy is what is known as the bubo, hence the term bubonic plague. And here you can see swelling in the upper thigh, in the inguinal region, in a case of bubonic plague. Septicemic plague develops after infection with untreated insect bites, or if the patient handles infected materials with broken skin that allows for entry of the infected biological material directly into the body. The signs and symptoms are similar to bubonic plague, but it's sometimes associated with hemorrhage, and characteristically, you can get gangrene of the distal parts of the limbs. So this is an example of where there is gangrenous development of the distal phalanges of the fingers and the nose in this individual. Pneumonic plague is the most virulent of the three clinical forms of plague. Most virulent, but thankfully least common. Mode of transmission is human-to-human droplet spread. Once it develops, it affects the respiratory system, and it results in rapid progressive pneumonia, respiratory failure, and shock. So let's look at influenza now. Influenza is caused by orthomyxovirus family of viruses, of which influenza A and B are the prototypes, and they are responsible for the seasonal flu. That's why every year we have to get our annual flu shot. Some immunity against influenza is obtained from previous infections, but vaccination is the main form of providing immunity. The at-risk groups for the development of viral infections with influenza are the extremes of age, infants and the elderly, immunocompromised persons for whatever reason, and those with underlying chronic illnesses. Pandemics have occurred with global outbreaks of new strains of influenza. And if you recall from the pandemics that were present in the 20th century, they were mostly as a result of influenza A, Spanish flu, swine flu, Asian flu. Little or no immunity develops, is associated as a result of lack of previous exposure, but they have constituted the major public health threat prior to the emergence of COVID-19. There have been 3 strains in the 20th century: the Spanish flu, which we already discussed, the Asian flu, and Asian flu has the notoriety of being the first pandemic to occur after the establishment of global surveillance systems. And thirdly, the Hong Kong flu, 1968 to 1970, in which vaccination, hospitalization, and treatment of superimposed bacterial infections with antibiotics significantly reduced the fatality burden. Swine flu, another influenza A viral infection, which emerged between 2009 and 2010. Thankfully, only 150 to 600,000 deaths, but this again was the first pandemic that was effectively dealt with by a combination of vaccination and antiviral drugs. But to date, swine flu still circulates in small numbers as a seasonal flu. Chikungunya. So chikungunya is a mosquito-borne viral illness caused by an alpha virus. It's typically seen in Asia and Africa, but in 2013, cases appeared in the Caribbean, the Americas, and in Europe. Symptomology, non-specific: fever, arthralgia, myalgia, fatigue, and rash. There's no specific medical treatment, no specific pharmacological treatment. Treatment is supportive and symptomatic, relief of symptoms. To control this disease, you have to control the vector, which is the mosquito, and it's rarely fatal, rarely fatal. Zika is another mosquito-borne illness caused by a virus of the flavivirus family. It was first identified in monkeys in Uganda in 1947, with the first human case occurring 5 years later. Outbreaks have occurred in the Americas, the Caribbean, Africa, Asia, and the Pacific, as is the recurring theme in the clinical presentation. Symptoms are non-specific, but thankfully most cases are asymptomatic. Of clinical significance is that infection of pregnant women with Zika virus in the early stages of pregnancy could result in either miscarriage, preterm birth, or those pregnancies that go to term and delivery of a live infant. Congenital Zika syndrome can be manifest in the product of that pregnancy. And congenital Zika syndrome is associated with microcephaly, smaller than normal head, as well as other congenital anomalies. And this photo, these 2 photos on the right, is an example of congenital Zika syndrome. Affected adults have an increased risk of developing the ascending polyneuropathy, Guillain-Barré syndrome, other neuropathies, as well as myelitis. No specific medical treatment exists, and you control the disease by controlling the vector, the mosquito. SARS. So SARS is caused by a coronavirus, a beta coronavirus. It was first identified in China in 2003. It was spread by droplet infection, and since its emergence in China in 2003, it has spread to the Americas, Europe, and Asia. An unprecedented public health response to SARS halted its spread otherwise. So thankfully, there were only 8,000 infections with a 10% fatality rate. Only 800 deaths occurred as a result of SARS. The last known case was in 2004, and it was a laboratory-acquired infection. So we haven't had any community spread since then. Clinical presentation, non-specific. After 2 to 3 days, cough, pneumonia, dyspnea, hypoxemia. 10 to 20% of cases require intubation and mechanical ventilation. And the control measures, the public health control measures, are the same as for COVID-19: surveillance, quarantine of identified cases, social distancing to prevent spread, use of masks, and hand hygiene. MERS, caused by MERS-CoV virus, is another beta coronavirus, emerged in 2012 in the Arabian Peninsula. It has been reported in 24 countries throughout the Middle East, Europe, Asia, Africa, and North America. Thankfully, again, only 1,000 cases on the books with 400 deaths. Ebola. Ebola is one of the viral hemorrhagic fevers. It's caused by 2 genera of viruses that belong to the Marburg and Ebola species. These are SS envelope RNA viruses of the filovirus family. There are 5 Ebola species, with the Zaire Ebola virus being the most common, with the highest mortality rate. 80% of infected people die. And this virus, the Zaire Ebola virus, was responsible for the first recognized outbreak. Less common species are the Sudan Ebola virus, which first appeared in 1976 with a 50 to 60% mortality. The Western Ebola virus, which is endemic to the Philippines in animals and does not cause human disease. The Côte d'Ivoire Ebola virus, and the Bundingyo Ebola virus. So Ebola predominantly affects sub-Saharan Africa, as is shown on this map, with the different colors showing the different subtypes. The first outbreak of Ebola occurred in August 1976 as a result of the Zaire Ebola virus in Zaire. Patient 0 was a 44-year-old male school teacher who lived in a remote village in the Congo near the Ebola River, hence the name Ebola virus. He presented with the non-specific symptoms and was initially misdiagnosed as malaria because of the non-specific nature of the symptoms, and these non-specific symptoms are shared in common with many of these viral infections. And he eventually died as a result of profuse hemorrhaging. Because he was the index case and had been in contact with his family, there was spread of the infection throughout his immediate family to other contacts in the hospital, as well as other contacts in the hospital in which he had been treated, as a result of the then reuse of needles. So this is something that would not occur today. The reservoir of infection for Ebola virus appears to be the fruit bat, so an animal reservoir for the Sudan and Zaire species. It causes epizootics as well as human epidemics. So epizootics are outbreaks within the animal reservoir. And how does it jump the animal species? It's as a result of the non-human primate reservoir and bats being hunted by humans, placing them in contact with the infected material. And epizootics tend to precede human outbreaks of infection. This virus tends to show outbreaks every few years, but they're usually limited to sub-Saharan Africa. And within the last 2 weeks, we would have seen in the news that there has been a warning of a recent outbreak again of Ebola. The 2014 outbreak affected 12 countries, causing approximately 29,000 infections and 12,000 deaths. Ebola virus, it spread via contact with infected bodily fluids or biological material from infected animals, bats, porcupines, primates, again, which are hunted. The presentation is non-specific again, but similar to malaria and typhoid fever, hence why the index case was misdiagnosed as malaria, but then you develop the bleeding disease and you end up with unexplained hemorrhages, bruising, etc. There are no proven treatments. You have to replace fluid for the blood loss, and an experimental vaccine in 2015 showed some success, and it was used in the Democratic Republic of Congo outbreak. So let's come to the meat of the matter now. New kid on the block, the novel coronavirus. So this is believed to be a probable zoonotic viral respiratory disease, which we all know emerged in China, probably Wuhan, and it exhibited rapid geographical dissemination throughout the world, which accounting for the pandemic, which has affected us adversely for the last 3 years or so. It was able to spread rapidly and wreak havoc because of the ease of international travel. In the early phases, ease of community spread because of lack of hygiene, no masking, no hand hygiene, etc., as well as the vulnerable populations, those with chronic diseases. It's a respiratory disease that starts off as an upper respiratory tract infection that progresses to viral pneumonitis with ARDS type features clinically and pathologically. Acute respiratory distress syndrome, otherwise known as diffuse alveolar damage. Once ARDS sets in, clinically, you get a respiratory failure. The patient becomes ventilator dependent, again, similar to SARS and MERS. There was no cure, and when this presentation was first developed, there was promise of a vaccine, promising vaccine. However, we know that the vaccines have been effective. So SARS-CoV-2 is the cause of COVID-19 disease. It's an RNA virus, and the prefix corona refers to the sun-like spike protein projections that project outwards from the spherical surface of the virus. These spike proteins bind to angiotensin converting enzyme type 2 receptors, which are very prevalent in type 2 pneumocytes in the lungs. Hence, this virus wreaks its significant morbidity on the respiratory tract, more so the lungs. Disease progression, so fever, cough, dyspnea, mostly a self-limiting cause, and the extent of the progression or the severity of the progression is dependent on the age of the individual and the comorbidities. And we all know that those with cardiovascular disease have a very high fatality rate, 10.5%, diabetes in second place, underlying chronic respiratory diseases, hypertension, etc. The pathology. The universally agreed, universally demonstrated pathology in COVID-19 disease is in the lungs, which is manifested as diffuse alveolar damage and viral pneumonitis. Again, similar in pathological presentation to SARS. Novel observations have been detected in have been made in some cases. You can get myocarditis, lymphocytic myocarditis, secondary to viral infection with COVID-19. There are some changes in the central nervous system, which is still under investigation, some vascular changes, and development of a hypercoagulable state, but thankfully these are not very prevalent. These photomicrographs are from one of the earliest publications on COVID-19 disease. And they show, top left, this is a low power view of the lung, which shows slight increase in cellularity of the alveolar spaces. And at higher power, you can see these thick hyaline acellular proteinaceous membranes. These are the hyaline alveolar membranes, which sits on the surface of the alveolar walls, interrupting gas exchange, and this is what clinically is responsible for the ARDS type changes, the acute respiratory distress syndrome. Pathologically, this is what we call diffuse alveolar damage. In contrast to bacterial infections, where you have a lot of inflammatory cells in the alveolar spaces and in the interstitium, classically, COVID-19 is associated with a paucity of inflammatory cells, a paucity of inflammatory response. And here you can see some type 2 pneumocyte hyperplasia. So this is the typical finding of COVID-19 disease. The only prominent finding are these eosinophilic hyaline membranes, which line the walls of the alveoli, preventing exchange of oxygen and carbon dioxide. The earliest work on the central nervous system showed that the virus enters the CNS through the olfactory mucosa in the nose, and this is immunohistochemical staining of the olfactory mucosa in the nasal cavity, showing a positive response for antibodies raised against COVID-19, SARS-CoV. Work is still ongoing right here at the Ottawa Hospital. Dr. Schlossmacher, who is a neurologist, he has been looking at the olfactory bulbs, as well as the nasal mucosa, as well as the brain, together with a neuropathologist, trying to sort of work out the method of infection and the pathology that affects the CNS that gives rise to the clinical symptom of brain fog. So that's still a work in progress. Post-mortem considerations. So as a forensic pathologist, I may be asked to perform a post-mortem examination on a known COVID-19 case. So what are the post-mortem considerations? What things do we have to think about when we are attempting to consider doing a post-mortem? Well, one, how long does the virus live in a dead body? It's unknown, but there's no reason to believe that the post-mortem infectious risk is exceedingly high. Should autopsies be performed on COVID-19 positive cases? Yes, under specific circumstances. And in my field of work, as a forensic pathologist who performs medical legal autopsies, there must be a clear medical legal indication to do a full invasive autopsy on a known COVID-19 positive case. How should that autopsy be performed? Well, research protocols have been developed with health and safety considerations, and those have been adopted now as standard in our approaches to these cases. And as I said before, there must be case-specific compelling medical legal issues that can only be addressed by an invasive examination of the body. So if we have somebody who was diagnosed last week with COVID-19 disease and was symptomatic, and they were shot, stabbed, or strangled, that's a compelling medical legal reason we would have to proceed with a full invasive examination despite their COVID-19 positive status. How should the autopsies be conducted? Well, it depends on the purpose. If it's a homicide, it's the full Monty. We do the full conventional invasive autopsy. But in other scenarios, we can adopt a minimally invasive approach as is necessary to answer the specific medical legal issue. So if the medical legal issue is, okay, this person is COVID-19 positive, but clinically it's believed they suffered a ruptured berry aneurysm, then we may only open the head to document the presence or absence of a ruptured berry aneurysm. We may not open the chest and abdominal cavity and dissect those organs, or vice versa. How should they be conducted? Again, we need a negative pressure room to pull aerosols downwards and away from our nose and mouth, as well as we need to adopt health and safety precautions to prevent the production of aerosols, or if aerosols are produced, to prevent their inhalation. So we use an N95 mask, and we use downdraft tables with downdraft ventilation. What is the current practice in Ontario? Well, we would only do targeted examinations on COVID-19 cases for medical legal reasons only. Burial, do you bury or cremate? Either is acceptable. There is no special preparation that has to occur from a health and safety perspective once the postmortem is completed to facilitate burial or cremation. So, the postmortem precautions that we have to put in place are all aimed at reducing the risk of production of aerosols. The risk of contracting COVID-19 disease, of being infected with SARS-CoV-2 virus, has to do with the inhalation of aerosolized biological material that contain virus. So anything that can reduce the production of aerosols or prevent us from inhaling any produced aerosols is what we utilize. So how can we reduce the production of aerosols? In standard cases, standard autopsies, we use an oscillating saw to cut through the ribs to open the chest cavity. The use of an oscillating saw at high oscillating speeds inherently produces aerosolized particles of bone, which theoretically could have viral particles. So in its place, if we're dealing with a COVID-19 case, we don't use the oscillating saw, we use a rib shear. So we use a pair of rib shears to manually open. We have an alternative, rib shears to open the rib cage, but we can only use the oscillating saw to open the head. We have no alternative. So if we can get away with answering the medical legal questions without opening the head, we won't open the head. However, if opening the head is indicated, then how can we control the production of aerosols? Well, we have developed a technique here where we use the oscillating saw in the largest size Ziploc bag to control the, to limit the produced aerosolized particles of skull bone in the bag. Secondly, we want to minimize the infectious burden of the lung itself. So what we have resorted to is inflating the lungs with formalin at the time of postmortem, allowing them to fix for a number of days and then dissecting the lungs. Formalin kills everything. So just to give you some pictorial representation, this is the typical PPE. So we use surgical aprons here at the Ottawa Hospital, surgical gowns. We have a plastic apron over that, armlets, N95 masks, gloves, boots, etc. So full PPE. This is oscillating saw in standard case, non-infectious case, and this oscillating saw is used to saw through the skull. It's also used to saw through the anterior chest wall, through the ribs, to open the chest cavity. This is how we have adapted the use of the oscillating saw. So we use a large Ziploc bag. We occlude it at the neck of the bag, around the neck of the patient. There's a hole in the bag through which the saw is passed, and we use duct tape and we fasten it. And that's how the saw is used. So we control the production of the aerosols to this bag and not the entire room. This is the trachea, which has been divided, and using a narrow plastic tube and a funnel, we instill formalin into the trachea, into the main bronchi, into the bronchial tree and the alveoli. This technique has long been in use for active TB cases. If we have to do an active TB case, this is how we approach it. So we've just adopted it. These are some more examples of the lung pathology in COVID-19. You can see a slight increase in the inflammatory cells, some type 2 pneumocyte hyperplasia, alveolar hyaline membranes, etc. So what are the medical legal issues associated with these cases? So public health considerations, screening of deaths in the community using post-mortem nasopharyngeal swabs to see who is positive and who is negative, so we can adapt our approach to the post-mortem examination. We use this in a triage manner. We triage the risk based on the clinical symptomology, and if necessary, we take a nasopharyngeal swab in the post-mortem setting. We take the swab today, the results are reported the next morning. If it's negative, we go ahead with our conventional autopsy. If it's positive, then we adjust our internal examination as necessary. This approach allows us to deal effectively with cases in which the cause of death is unclear. Did this person die from COVID-19 disease, or did they die with COVID-19 disease but from something else? So when there is a potential for a competing cause of death, we have to adopt that approach, as well as we use it to triage, to look at the quality of care in long-term care facilities, etc. So how are we doing for time? 12:48. So quickly, 3 types of cases we encounter in medical legal practice. We can have a SARS-CoV-2 positive death, positive case, but the cause of death is unrelated. Secondly, we could have fatal COVID-19 disease in the community. Or 3, we could have fatal COVID-19 disease in the elderly. In the first category, we've seen those with COVID-19 positivity die from other things: strangulated inguinal hernia, glioblastoma, or hypertensive intracerebral bleed, hypertensive stroke. Fatal COVID-19 in the community, we see it at a range of ages. We have also seen it in otherwise healthy young adults. And those fatality in the elderly are those with COVID-19 comorbidities. So I'll just go through one of the 3 cases to allow some time for questions. So case number 1, 77-year-old man, history of systemic atherosclerosis. He was exposed to COVID-19 disease in the community, developed symptoms of upper respiratory tract infection. Symptoms progressed, exhibited dyspnea, and developed respiratory failure, and he died. This is a section of his fixed lung. So this is formalin fixed lung. And this is his histology. This is the mucosa, the mucosal epithelium. There's some postmortem detachment. There's some inflammatory cells in the mucus on the surface epithelium. This is a higher power of it. Nothing really striking. This is what his lungs look like. Basically, there's no inflammation apparent here. There's no pneumonia. Hyaline membranes are not very conspicuous. This is atherosclerotic change in a branch of his pulmonary artery. A bit of inflammatory cells in an airway here. Higher power, you can appreciate a mixed inflammatory cell infiltrate in this bronchiole. And then in this section, you can now see the thick hyaline membranes. So the diffuse alveolar damage in his case wasn't global, it was patchy, but it was enough to cause his death. And again, another section in which you can see the thick hyaline membranes lining the alveolar walls in the absence of significant inflammation or significant inflammatory exudate in the alveolar spaces, which are these clear spaces. Another high power view, you can see the thick hyaline membranes. This is the diffuse alveolar damage. This is his kidney. So this is benign nephrosclerosis. This is what you see in hypertension, not contributory to his death. This is his heart. This is the endocardial surface of the papillary muscles. He has a localized scar here. So he has underlying ischemic heart disease. So his cause of death was signed up as 1A COVID-19 disease based on clinical pathological correlation. And in part 2, atherosclerotic and hypertensive cardiovascular disease, as well as chronic obstructive disease. And I will stop there to allow for some questions. So in summary, we live in an unprecedented time. Despite the advances of modern medicine, the world population is constantly under threat of new and re-emerging infectious diseases. And for all of us, this must be concerning. The current COVID-19 pandemic has radically changed our way of living, our way of life, and in fact, how each of us view life. How long will the pandemic last? We don't know. What other infectious disease will follow COVID-19? We don't know. However, medicine and science have to be concerned about all of these, and as such, have to exhibit a degree of vigilance so that at the next outbreak, we are ready to deal with it. So just want to acknowledge Dr. Anton Small, resident in anatomical pathology at the University Hospital in West Indies, Mona, Jamaica, who had helped me develop this presentation when I had first done it, and Dr. Michael Polana, Chief Forensic Pathologist, who had provided some of the photomicrographs as his unit had done some of the earliest cases of COVID-19 autopsies in Ontario. So thank you very much for that.
That's excellent. Thank you so much, Dr. Walker. Thank you for leaving some time for questions. We look forward to those. I note that on the front page of the Globe and Mail this morning, there was an article about the Black Death and how, in fact, it still continues to affect us genetically. 50% of the world's population, up to 50%, as we know, was threatened by the Black Death that you mentioned in the late Middle Ages. And it has shifted our genetic composition as humanity. And for instance, it is thought that some diseases currently problematic, including autoimmune diseases, are as a result of the Black Death many, many centuries ago. So lots of uncertainty around where this current pandemic is headed, as you note, but I welcome questions from the audience. We have some minutes for that. And Dr. Walker, if you're available to stay a few more minutes after 1, we appreciate it. Thank you.
Yeah, I have to leave just at 1 because I'm on autopsy duty and I'm supervising my resident, but I can stay until 1.
Okay, thank you. Questions from the audience? Maybe I'll start. You rightly note that we don't know how long the current epidemic will last. Could we learn from history? Could we learn how long it will be before we incorporate COVID vaccines into the yearly flu shot? Could we learn about measures, including One Health, around tracking epizootic outbreaks? What lessons from your field, we've been talking about lessons we're bringing forward in primary care, but what lessons in your field can we bring forward? Noting, of course, that infectious waves are only one of the phenomena. We also have to think of impacts on mental health, impacts on communities that are ongoing. But what historical lessons would you bring forward, Dr. Walker?
That's a tough one. I think it would be the epidemiologists and microbiologists who would be better placed to, assess the response to the global response to the COVID-19 pandemic and compare it with previous epidemics to see, what additional knowledge was gained so that it could be applied for future pandemics. Unfortunately, I can't answer that. I only see dead people. I don't see
But
the big I don't see
yeah,
the big epidemiological picture.
yeah. But your view is very important to us. These rounds are interdisciplinary, and we get new and fresh ideas from all sorts of perspective. That's what this is all about. A question here from a CFPC member: what % of the cases show hyalinization?
So the fatal cases, because we would only see the fatal cases, those who have died from COVID-19, they're going to have it. That is what takes them out. That accounts for the respiratory failure. So I would say close to 100%. But then my population would be biased because I'm seeing the fatal COVID-19 disease. Those who are COVID-19 positive but died from some other catastrophic discernible pathology may not have the diffuse alveolar damage. But certainly those who have died from it would have it.
Very helpful. That's great. Janet Hatch Roberts notes that age-old measures such as hygiene are the most important indeed. Chuck has a question. Chuck, you have your hand raised. Go ahead.
Yeah, hi, thanks. Thanks for the presentation. Just wanted to clarify a couple of things. Although there is no cure, that's not necessarily true. There's a lot of therapies that can and should be used for patients, especially early on and high-risk patients. As a side, I'm the chief of infectious diseases and immunology and allergy at CHIO and professor in pediatrics, University of Ottawa. So not only is that, but the vaccine is actually stunningly effective. It decreases deaths. There was recent CDC publications, and there's huge publications, at frail, elderly, and others out of the huge databases out of the UK and Israel and around the world, looking at decreasing deaths in high-risk populations by the order of 80 to 90%. So by any measure of a vaccine effectiveness, this is stunningly important information and has huge prevention worldwide. The vaccines are not very good in terms of preventing infection, but the hospitalization and the serious complications, including death, are quite important. To answer the question about future epidemics or pandemics, I think we really need to kind of really look at global health surveillance and international health regulations, which have fallen short now 2 times, Ebola and also now COVID, SARS-CoV-2. We don't have a strong surveillance network, nor do we have a lot of teeth associated with IHR. So, global public health has to work, strongly in that, but there's a huge amounts of competing priorities. Global health security, in addition to just global health, is all, they sometimes are at loggerheads associated with this issue.
Absolutely. Thank you very much, Chuck. We're at time. Those are some wise closing words. Thank you very much to Dr. Walker for your wisdom, historical perspective, and engagement. Please fill the survey on your screen, and please feel free to be in touch around future topics for the series. And we hope to be in person, let's hope, after the next season. Thank you again, and please stay in touch. Thank you, Dr. Walker.
Okay, just before I go, I just want to say thanks for the opportunity. On, I think it's December 6th, as part of the bi-weekly grand rounds of the Department of Pathology and Laboratory Medicine, one of the COVID-19 vaccine researchers is going to be giving a lunchtime presentation on the vaccine development process. So if someone can send me an email request, I can forward the link, which could be disseminated throughout those who are interested in the global health initiative. I don't have oh, here it is. Yeah, December 6th, Dr. Francisco Diaz Mitoma from VBI Vaccines is going to be speaking on the vaccine development process. Next Tuesday, the 25th, Anton Small and another resident from UE Mona are going to be talking about the history of vaccine development. So they are going to be tracing, you know, how the very first vaccine was identified, etc. And then on December 6th, Dr. Diaz Mitoma is actually going to go through how vaccines are developed from concept, laboratory testing, you know, different phase trials until it's rolled out. So if someone sends me an email, I could forward those two links. It's all Microsoft Teams.
Thank you very much. MJ has volunteered. Thank you, MJ. And thanks to everyone. It continues to be great to share perspectives at this critical time. Thank you.
All right, bye.
Bye-bye.